Good morning. My name is Matt and I'm a physical therapist at the Sports Health Center as well as the Cleveland Clinic Independence Family Health Center. How do you explain 6 to 9 months of ACL rehabilitation within a 15-minute presentation? It's kind of like building a suit of armor for your patient. And today I'm going to present a layered progressive framework for ACL rehab based off the best available evidence. Because research shows that patients have alarmingly unrealistic expectations when it comes to ACL rehabilitation. Some days I feel like the patients think that just because they had the surgery, that life is going to magically go back to the way it was before they got injured. Unfortunately, the truth is that research shows that 20 to 40% of all ACL reconstructions will fail. Less than 60% of them will be able to return back to their prior level of sport, and more than half of us will go on to develop early onset osteoarthritis. A physical therapist's job ideally starts before surgery, as a recent American Journal of Sports Medicine cohort study compared return to sport rates between the Delaware, Oslo, and Moon cohorts, with the difference being that the Delaware patients did significantly more preoperative physical therapy, including neuromuscular training and progressive strengthening past simple symptom resolution. 2 years post-ACL reconstruction, 72% of the Delaware-Oslo patients had returned to their prior level of sport, versus only 63% of the Moon patients.
Damage report? That's comprehensive. Show me something.
Preoperative PT should be more than just simple symptom resolution. It should be seen as physical preparation for a period of decreased mobility and significantly reduced activity, because immediately post-op, emphasis is on damage control and avoiding common complications, such as persistent quadriceps weakness or loss of knee range of motion.
So the Mark 7 is not ready for deployment. Then skip the spinning rims. We're on the clock.
With loss of knee range of motion being the most common complication, which can lead to altered gait and persistent lower extremity weakness. And we may actually be on the clock, as a recent Orthopedic Journal of Sports Medicine cohort study demonstrated that a patient's knee extension range of motion at 4 weeks statistically significantly correlates with their range of motion at 12 weeks. And another recent Orthopedic Journal of Sports Medicine case control study looked at ACL reconstructed patients who required cyclops lesion removal to regain their full knee range of motion. 3 weeks post-op, 71% of these patients that required arthroscopic removal of the cyclops lesion demonstrated an extension deficit of greater than 5 degrees compared to the uninvolved side. At 6 weeks, 60% of these patients had greater than a 5-degree deficit. All of this just makes regaining the patient's range of motion your #1 priority and first layer of ACL rehabilitation. However, in addition to tissue restrictions, lack of terminal knee extension may also be related to arthrogenic muscle inhibition of the quadriceps, which is why early reactivation of the quadriceps is incredibly important. And a recent Level 2 systematic review in the Journal of Knee Surgery, Sports Traumatology, and Arthroscopy concluded that neuromuscular electrical stimulation with physical therapy exercise appeared to be more effective at increasing quadriceps strength, knee function, and self-reported outcome measures compared to physical therapy exercises alone. Now, reactivating the quadriceps and restoring a patient's knee range of motion is ultimately done to normalize their gait pattern, with altered gait potentially being linked to early OA progression and an increased re-injury risk. And a longitudinal observational study recently done in the Journal of Clinical Biomechanics demonstrated that asymmetries during gait at 4 weeks statistically significantly correlated with asymmetries during gait and running at 12 weeks post-op. Here, if you take a look at this patient's left knee, you'll see that she lacks terminal knee extension. and this inhibits her ability to properly strike her heel when she walks. The first layer is restoring normal range of motion, muscle function, and a proper gait pattern. Once we do this, the second layer can be defined as double and single leg strengthening, and it starts with the quadriceps.
3, 2, 1.
A recent British Journal of Sports Medicine prospective cohort study demonstrated that a more symmetrical quadriceps strength prior to return to sports significantly decreased re-injury rates. For every 1% increase in strength symmetry, patients demonstrated a 3% decrease in re-injury rate. Also, a recent systematic review and meta-analysis in the journal OA and Cartilage has shown an association with knee extensor weakness and increased risk of osteoarthritis. Journals from this systematic review included things like late-stage arthritis and joint replacement surgery, as well as articles that incorporated ACL rehabilitation and reconstruction. The squat is a great exercise that creates a knee extension moment, requires trunk control, as well as coordination of the hip, knee, and ankle joints, and it can also be used as an assessment tool. A recent biomechanical study in the journal The Knee showed that ACL reconstructed patients do this exercise differently compared to healthy, uninjured controls. In this video, you can see that the patient weight shifts to the right, which is away from her surgical side. And in this next video, you can already see that the patient lacks terminal knee extension and that she is unable to achieve a 90-degree flexion angle in her knee when she squats. Also, the study demonstrated that ACL reconstructed patients had differential joint loading patterns compared to normal healthy controls. But it's not just about the quadriceps muscles. Decreased hamstring strength and a quadriceps dominant hamstring to quadriceps ratio has been identified to place the ACL at increased risk. A normal hamstring to quadriceps ratio is approximately 60% or 0.6. And a recent Level 2 International Journal of Sports Physical Therapy systematic review found that the single leg squat exercise seen here produced the ratios closest to that 60%. Also, the single leg balance aspect of this exercise leads us to the next layer of our rehab, which is when can the patient start running? There's no established protocol for this, but we do have some tests that mimic the physical demands of running. To begin with, single leg stance is crucial during running. An increased knee valgus has been identified as a primary predictor of ACL injury. The single leg squat test seen here allows you to view the patient's knee valgus as well as their trunk and pelvic control, or in this case, the patient's inability to control her knee valgus and trunk and pelvic control. A recent Orthopedic Journal of Sports Medicine cross-sectional study linked increased knee valgus with significantly decreased hip abduction strength, as well as a significantly decreased single leg hop for distance. In addition to single leg control, the single leg step down tests lower extremity endurance by comparing the number of heel touches that can be performed in a given amount of time to the uninvolved leg. A recent prospective study in the Journal of Medicine and Science in Sports and Exercise showed that increased single leg stance step down scores at 3 months were able to predict sagittal plane knee running mechanics at 6 months post-op ACL reconstruction. Finally, the Y-balance test seen here challenges dynamic single leg stability in multiple directions. A recent International Journal of Sports Physical Therapy retrospective cohort study showed that patients with anterior deficits of greater than 4 centimeters compared to the uninvolved side at 12 weeks were not able to achieve a 90% limb symmetry index for the single leg hop and the triple hop for distance at return to sport testing time. Once we have symmetrical knee range of motion and near symmetrical single leg stability, a normal gait pattern, and normalized lower extremity strength, the patient can begin to return to run. The next step or phase in our rehab is double leg jumping. Drop landings are a great way to begin a jumping progression because they can start from low and progress to higher elevations. Also, they can be used to evaluate global lower extremity function and postural control during a functional movement pattern. And a recent controlled lab study in the Journal of Athletic Training showed that ACL reconstructions demonstrated a larger number of biomechanical errors versus healthy controls. And this larger number of errors negatively correlated with the patient's knee extension strength. Those biomechanical errors that we're looking for are similar to the same things we looked for in the double leg squat and the single leg squat: trunk and pelvic control and increased knee valgus. Can anyone tell me which knee this patient had surgery on? If you said left, you would technically be correct, but technically this patient had surgery on both legs. The left leg was the one we were working on at the time. After double leg jumps naturally comes single leg jumps, and researchers agree that return to sport decisions should be based off a battery of functional tests, including the following single leg hop tests. With the first being the single leg hop for distance. The patient is instructed to balance on one leg, squat down and jump forward as far as they can, maintaining their balance on their single leg. A recent prospective cohort study in the Journal of Knee Surgery, Sports Traumatology, and Arthroscopy showed that this single leg hop was their strongest predictive parameter for determining whether a patient would be able to return to their prior level of sport. Next is the triple hop, which is 3 consecutive single leg hops for distance, again making sure the patient maintains their single leg balance upon their landing. This is followed by the triple crossover hop that adds a diagonal component to the jumping. And then finally the 6-meter timed hop. The patient is instructed to balance on one leg, and when you say go, hop on that one leg as fast as they can across a 6-meter finish line. Scores of these lower extremity functional tests are compared to the uninvolved leg to create a limb symmetry index, with the surgery leg being divided by the non-surgery leg, with the goal of the surgical leg being at least 85 to 90% as strong as the uninvolved side. A recent AJSM cohort study was able to show strong test-retest reliability for these single leg hops, and rehab experts agree that you should use them. However, research has struggled to create a strong link between these tests and decreased re-injury rate, or even whether patients are ready to return to sport. Which brings us to the ultimate question, which is when can a patient get back to their sport?
I'm limited by the technology of my time, but one day you'll figure this out. And when you do, you will change the world.
While we don't yet have a consensus answer to this question, despite what I've already presented, still the #1 surveyed factor used when determining whether a patient can return to sport is simply the chronological time from surgery. despite the fact that a 2012 American Journal of Sports Medicine controlled lab study demonstrated that significant lower extremity asymmetries can still exist in patients even after they've begun transitioning back into their sport. However, a recent British Journal of Sports Medicine clinical practice guideline, underpinned by systematic reviews, states that an extensive battery of functional tests should be used when determining whether a patient can begin their return to sport progression. At the very least, it should include strength testing, hop testing, and movement quality testing, with the patient achieving at least, if not greater, than a 90% limb symmetry index compared to the uninvolved side.
This is a flight stabilizer. It's completely wrong.
Also, sports reintegration isn't something that you just decide to do on a whim. It needs to be done gradually to combat the lack of confidence and fear of re-injury that go with a patient trying to get back to a sport that just cost them the last 6 months of their life. Practices can be begun without contact, followed by incorporating contact, leading to friendly or team scrimmaging, followed by actual competition and eventual resumption of their prior level of sport. So when patients ask you about ACL rehabilitation, tell them to suit up, because until a higher level evidence-based return to sport criteria is available, each rehab phase or criteria progression should be looked at as layers of protection applied across a continuum of recovery, just like building a suit of armor. This gives us the best chance to address all of the patient's functional deficits and gives them the best chance of having a successful outcome, which is getting back to the sport that they love. Thank you very much.